Welcome back, everybody, to the trauma, no, not the trauma, the Kinship Foster Adoptive Parents podcast for West Virginia. I'm Sky Kirshner, and I'm here with Dina Shelton in Texas, Marissa Sanders, who's by her lake, and Stacy Jacks, who's on the beach, or at least it appears that way. And we're going to talk today a little bit about trauma-informed care. And we've had a couple episodes where we were talking about different kinds of therapies and what to look for in a therapist. And I wanted to kind of put out the idea that there are different kinds of trauma-informed or trauma-sensitive care, but part of what this means has to do with what kind of welcome you receive when you have the first contact with whoever the person is, whether it's a therapist, a medical person, or somebody in the government system. What is that first contact like? And we know that when folks have attachment kind of issues, which who doesn't, but the welcome, the initial, that first impression idea, it really is true, especially around when you've had disruptive attachments, because you're going to be trying to gather information about whether this is a safe person, this is a safe relationship, this is a safe agency or a safe place. So I wanted to kind of kick us off by showing a little video, and then we'll kind of respond to the video of this is a teenage woman who's showing up at a hospital. She's there to meet her psychiatrist. This is from the TV show New Amsterdam. And it's just going to go for a minute. And I just want to kind of think with you about in what ways is this trauma informed and in what ways maybe is it not trauma informed. So can everybody see the, Marissa, give me a thumbs up if you can hear it as well.
Let them know groups in 10 minutes. So that's the OC method.
Yeah, I know. They told me that I was going to back.
Dr. Frome, please sign in and take a seat. Dr. Frome. And lady, it is way too early in my day to call security, but I will. Dr. Frome! Dr. Frome! Dr. Frome! Dr. Frome!
All right. Like I said, a very quick video. What's going on in that video? And does that look like that's trauma informed or maybe not so trauma informed? What did you notice about what's happening in that video?
The first thing I notice, and it drives me nuts at doctor's offices, is the glass barrier there, which, and the days of COVID, I certainly understand why we often have that, but you feel like you're talking to nothing and you're not sure if anybody's hearing you and you're not sure. And I can see going, maybe you didn't hear me. I need this doctor, Yeah, that was the first thing I noticed.
Yeah, that's beautiful, Marissa. So before COVID, these things, and this one has chicken wire in it, right? So it's like, so whose danger is here? Who needs, how is that initial welcome? What else did you all notice? Stacy, did you have something?
I noticed that they had no idea who she was. Sky and Dina, you guys as therapists, you need to have a well-trained staff that is welcoming. You could be as welcoming as can be, but I'm not going to get to see you till I've been there for 45 minutes. And often the doctor's staff makes such a difference. And I found that fairly frequently the very good doctors have very horrible staff. And I don't know what that ratio is.
And but, I have found that too. When I find great staff, then I don't love the doctor so much.
And this is just an aside. I don't know how you guys feel about this, but the therapists that I like that work best with my kids will let me meet with them first, just me. So then when my kid shows up for the first time, it's not me talking about my kid and they know something about my kid to say hello and all that sort of stuff. If they insist on meeting with the kid in the first visit, then the kid feels put aside and shoved aside as people talk about them, or else they call you back to the room and you're back in the room for 5 or 10 minutes and the kid's wondering what you're saying. And it's better if you can do the intake by yourself without the child there. And I understand for insurance purposes, sometimes they feel like the child has to be there, but I think that's a bad model.
Yeah, and the kid's going to take their cues off of you. And if they get a sense that you know this person, you feel comfortable with this person, that's probably going to help things quite a bit. Dina, what did your What did you notice in that video?
The first thing that I thought about, of course, and being in a position where, Stacey, I do a lot of training for staff, people at different places, schools and places like that too, of understanding. 'Cause when we say words like trauma informed, what does it mean to be aware that other things could be going on beyond just what you're seeing? And asking people to step back and not make assumptions. So you see this girl who is not following social cues and guidelines at all. And the woman who's responding is responding out of her fully conceptualized place of what is supposed to be happening right now. And rather than getting curious and saying, what's going on here and how can I perhaps counterbalance this? There's just the harsh, you're going to follow the rules, or I'm not dealing with this. You're going to do it the way that I assume it should be done, even. Or I'm not going to do this. And so watching her just say, she obviously needs something. And my first thought was, this girl has no language around what she needs. She just knows who can help. And that's not what that woman was thinking.
Yeah. The girl, she's not even sure how to pronounce the doctor's name, right? She doesn't have the social skills to say, hello, I'm Judy Smith. I'm here looking for Dr. Froome. I'm not sure how to say his name. Can you help me here? She just comes up. She very tentatively says, Dr. Froome. And so one of the things we look at is, how do people get triggered and how did we contribute to the triggering of someone? So, the nurse, the nurse doesn't stand up. The nurse doesn't say, oh, you're looking for Dr. Froome. You're in the right place. Yes, welcome. I'm Samantha. What's your name? And do those little, it's all requests for behavior change. If we go back to, she's saying, sign in, have a seat. These are requests for behavior change. Instead, what would it be like to give a welcome and say, this is my name. What's your name? How did you found us? I know it's hard to find, give her some credit, reframe it a little bit, and then say, oh, would you mind signing the sheet? Now, sometimes folks, the objection will be, well, I don't have time for that. And if we give the nurse some empathy, I mean, she's on the phone, she's multitasking, she's got 100 things. Probably that chicken wire is there because maybe somebody did get attacked at some point. And so, but it feels like I don't have time for this. But if you think about what's happening and how quickly this escalates, it's going to take much more time, for security to come. And now we've got this whole thing going on. Whereas a couple friendly interactions, a couple normalizing, a couple interactions early on can save a lot of headaches later on. How might this apply either to those first contacts with your kids, or when you go to out, or you've got folks that you're interacting with outside? Other examples of folks that did this well, that's so interesting, Stacey, about the staff versus the professional.
It is, because the professionals don't think about that the staff needs to be friendly and welcoming.
Yeah.
And the staff just thinks, oh, the doctor wants me to get this form filled out and this form filled out. I need their insurance card. I need this.
Yeah.
And it's very different.
Nobody's saying, I'm glad you're here, or, we're welcome. And that's all, a lot of trauma-informed care has to do with the welcome. I'm amazed at how many medical situations I'm in, especially if I'm in a hospital, where 3 people will walk into the room, no one introduces themselves. I have no idea what their role is. I have no idea who they're just telling me what to do, right? It's all requests for behavior change. And they know my name, they know all sorts of things about me, but there isn't that reciprocity. So,
And I didn't mean to interrupt.
well, let me just finish one thought and then I'll hand the whole thing over. So, when we're thinking about what kind of therapist or what kind, I would say I'd be looking for a therapist who gives a warm welcome, above anything else. How does the therapist, and maybe also what kind of building are they in? Is it an institutionalized building, or is it a place where the person who's going to be doing the working comes out and says, hello, glad you're here. Did you have any trouble finding this? Go ahead, Stacy.
I was just going to say that this applies to many things in the foster care realm, not just therapy. For instance, a foster parent will walk into an MDT and everybody else has been in court together and they all know each other and nobody takes the time to introduce themselves. An MDT is a multidisciplinary treatment team meeting. And if you think it's confusing for the foster parent, imagine how confusing it is for the kid. And especially if the kid has to go to court or anything. I was recently in a situation with my son. He had to go to court for something and my mother was there along with us, and trying to explain it to my mother just so she would get comfortable without freaking out my son about what was going on was just challenging. But I think the key with trauma-informed care, whether it's going to the therapist or going anywhere else, is to lay it out ahead of time and then to have what happens meets your expectations. So you have to know what's going to happen and be comfortable with what's going to happen before your kid can. And if you're both going to a strange place, then you have to at least pretend like you're comfortable with what's happening.
Scott, when you're talking about the welcome, I'm thinking that for me, one of the things I look at in any, whether it's a visit setting where my kid is going to interact with the kid I'm caring for is going to interact with a bio family, or it's a pediatrician's office or a therapist's office, one of the things I'm looking at is not just my interaction with the person, but what does the room look like? Did they think about my child when they set up this room? Especially if it's a pediatrician or a therapist who's supposed to be serving kids. Are there toys in the room? Are there chairs their size? Are there things to do that show me that they have thought about, that it's not just an office where they want to bill insurance and talk to my kid for an hour. It's we've really thought about what kids need to make them feel comfortable here and put that into place.
And that's where I always go into there's two things going on in every scenario where someone is receiving help from someone else. And by someone else, that can also be the place, the office, not just the single person, right? But you've got content and you've got process. And what we're talking about here is there is a gap in a lot of places, process and helping people understand the process of what's happening. We have to have a lot more meta communication and a lot more information given without people asking to help them feel comfortable. We do this very naturally with children, but we forget that that has to happen with adults too in brand new spaces. Maybe even more so with adults in brand new spaces. Is it helpful because it helps set the tone and helps provide a balancing and an ease in a new environment. What I like to encourage parents, we can't go in and require that all of these offices achieve some type of standard. That's not really possible. But I do really like to empower parents to request and require that from their offices and put themselves in the place of an advocate for their kids. Kind of like what you said, Stacey, it is easy for us to feel intimidated, for us to feel, kind of a step back, and we have to move forward with our comfort in the space too. And that might look like asking for the staff to be more clear with our child and to say, hey, before doctor's offices, before you do, would you please tell her what you're about to do, what's going to happen? It's just going to help her anxiety or help her know what's going on here. Depending on what language you use. My daughter's comfortable with the word anxiety. And so I might say, can you give her the play-by-play of what's about to happen before you do it? And ask them to do the skills that they should be doing. And a lot of times what happens, because bless them all, especially medical workers and mental health workers right now, man, you talk about overloaded vicarious trauma. Every client is more acute than what they would have been 18 months ago. Everything is heightened beyond what it would have been. And you've got people who are carrying a lot themselves. And sometimes they just say, hey, can you give her a rundown of what this day or this appointment's going to look like? And you may want that information too. Sometimes you see the light going, oh my gosh, of course. So here's what's going to happen. And they go into what they know that they just haven't been doing because they don't have all the space, right? So we can serve as advocates too and ask for that in a way that may be just corrective for us instead of just seeing this global problem. That is a global problem in a lot of places, but we can still end up getting what we need in the moment and maybe even helping that system redevelop as we go too, right?
There's something about slowing down that seems to be really important, and having the time to ask questions. So like the provider who says, do you have any questions? right? And really, really making it okay to ask questions. Because I know, some folk, you might ask that, but the other person might not feel free to, doesn't know if you really mean it or not. But there's something about slowing down, even in the speaking. I've got some of my clients who say, "Scott, you talk so fast, it gives me a headache." It's like, oh, that's such important information, right? I can make that adjustment. I can slow down. Yeah, Stacy.
I was going to say, if I could just give a quick practical tip. Whenever I take as soon as you get a child, you have to take them for what's called an EPSDT physical, which is a very invasive physical. They're often behind on shots, so they want to give them a shot. The first pediatrician's office visit is often horrible. If it's at all age appropriate, I always take a doll. If it's a boy, we might take Spider-Man. If it's a girl, we might take a doll. And doctor, can you look in the dolly's ears first? So they know what's coming. So it's happened to the doll first. And my pediatrician's great about doing that.
So you're teaching them about trauma-informed care as you go along in the thing. That's such amazing advocacy. Wow.
So.
For me, something I have to do sometimes is call ahead. Like once you get into the regular routine of, it's a well check, or my son has a condition where he has to see a specialist every 6 months. And sometimes they do blood work and sometimes they don't. And so if he knows there's an appointment coming up, he's always saying, well, am I getting blood work? Am I not? He hates needles. He hates the blood work. So for me, knowing, is this an appointment where we have to do all the mental prep and bring all the things to get through the needle stick, or is it not? Is it just that we're going to talk and they might, do a physical exam and weigh and measure you kind of thing? And sometimes because it's 6 months apart, I don't remember which one we're on. So I might have to call the office ahead of time and say, can you tell me what to expect? Is this a well child visit where we're going to have shots or not? Those kinds of things, so we can prepare ahead for that.
And also every doctor I know is fine with the no ouchies at the first visit policy. No ouchies at the first visit. I'll bring you back in 3 days for shots. The nurse gives the shots anyway. The doctor's not going to really care if you want to do them that day or not. We always do no ouchies at the first visit, because how are you going to make a good impression on a kid who's already scared by coming in and sticking them with needles? No.
The dentist that we use, the pediatric dentist, it always blows me away. With the first couple appointments we had, she said, I'm just going to look in his mouth. I'm not going to use instruments. She said, this is all about building a relationship and building rapport and getting him to trust me so that we're not traumatizing him so he doesn't ever want to come back. We want that. And she's got fuzzy blankets and stuffed animals and TV on the ceiling. You can pick what you want to, all of them. Like, I went to my dentist and said, how come you don't have a fuzzy blanket for me? What's going on here? But yeah, having someone with that kind of, but I wonder if we can also talk a little bit about, when we talk about trauma-informed therapists in particular, what does that look like in terms of, I don't know, how you work with the child, the things that I remember kind of trying to figure out over the course of working with a therapist for one of my kids. Is this person really trauma informed? Is what they're suggesting in terms of strategies and things, do they really fall into a sort of a trauma informed category, or are we making it worse or not helping, or, those kinds of things?
Yeah. So, and I'll take that one, but I'm going to segue in from what we were talking about too, in terms of, Sky had said something about you're almost kind of giving them some trauma-informed information so that they can have it later, and you teach people as you go. I think as foster, adoptive, and kinship parents, we find ourselves doing that anyway, right? And sometimes we can feel a little salty about it. It's like, come on, people, this is not new, right? We're not the only ones who are doing this, but at the same time, if we carry that as part of our role as an advocate for our child, there is a certain sense of, there's a certain sense of broader change that we can create in the world. And I've never met a foster, adoptive, or kinship parent that didn't have a connection to that too, to make things better for this whole process and system. And so many ways, when we say the words trauma informed, and I'll talk about therapy in a minute, but when we say trauma informed in general, at its very basis, it means, do you have information that helps you understand that trauma changes all the rules? Even if you don't know how it changes the rules, if you aren't an expert in it, if you don't have all of the things or interventions to do. So when you talk about like trauma-informed school, right? Or school district, or a primary school, right? They may not have all the trauma, they may not have trauma-informed interventionists on, or trauma specialists on staff. They may not have all these interventions that are trauma specific, but if they recognize that trauma changes things, then they will at least pause and slow down, which is what we talked about too, and consider what we may need to do that may be out of the norm for, for any other child that may not have had trauma in their background. And so as a trauma-informed therapist myself, I've provided trainings for schools. And as parents, you could connect maybe even with people who could provide trainings for the schools. And you can make connections that way if you see a gap in what can help you and your family. But at the same time, making spaces and using your interactions as a way to continue to build that system. So then I just want to make sure that I said all that too, because again, it empowers us as parents to do more and to have our kids' needs met better. With trauma-informed counselors, that used to mean a much wider range of things now than what it does now. And Sky, you may want to speak to this and wrap this part up too. Usually if you hear that someone is a trauma-informed therapist, they have some type of specific training that has helped them frame how to engage with trauma. Used to, it was kind of, they had some education about maybe in school or things like that. It's rare to have someone say they're trauma informed if they don't have a specific training or certification that provides that. So you can look up, usually people will tell you what that training or certification is, and you can Google it and find out what that training, what it says about trauma, and just kind of get a blip about it. If you're interested in that, that's the first step. I would encourage you to see what is the frame that they're using and what does it mean to them. You also can ask your counselors that. You can ask your counselors about their credentials. When you say you're trauma informed, tell me what that means to you, because I know that's different counselor to counselor, therapist to therapist. What specific, interventions do you use? Tell me a little bit about your approach to trauma informed care. And you can ask them to do that in a consultation. Most counselors do consultations ahead of time anyway. So Stacey, even if they're not bringing you back at the first session, they may do a consultation ahead of time where they talk to you about what's going on and what's happening. Absolutely ask what it is and do a little bit of searching online to find out more about it, to see if that looks right or to see if it gives you more questions. And don't hesitate to ask them. You absolutely should have those answered.
Yeah, unfortunately, we're going to need to close down for a minute. I love, Stacey and Marissa, what you're saying about no ouchies, and I'm just going to look into his mouth without any instruments. And I would say it's not just what does the therapist know, but how does that show up in the waiting room? Because, and I would say that's where it counts, because the welcome, the sense of being, being put at ease versus being put on edge is so important. So a trauma-informed practice will be very intentional about helping the person feel at ease, and that the person is a person and not, something I'm going to do a procedure to. So that whole relationship building piece, that whole sense of welcome, I think that's a super important part of this component, and not just what the credentials are. Marissa, Stacey, final word.
That's good.
All right. Well, thank you all so much for being here with us today. We try to keep the episodes to 20 minutes. So join us again for another episode.